And when I read that, I was kind of furious because it didn't really make any sense, and it was clear, and I wrote about this for Secular Pro Life. It was clear that to anybody who's in practice that this is just not, it's not reality that they're talking about. Elective abortion care is not something that people need access to as a way to combat true medical emergencies. And
Hi there, this is Miriam Diallo, AAPLOG's Communications Manager, and I am not the host of today's episode, which if you're a longtime listener of this podcast, you'll know what that means. It means that our actual host, Dr. Christina Francis, and our guest came in thinking that they would just have a conversation that's long enough for one episode, but they ended up having such a good conversation with so much good content that we're splitting it into 2 episodes. So here it is. This is going to be part 1 of a 2-part conversation with Dr. Francis and Dr. Sean Hutzler, an emergency physician, discussing EMTALA, the Emergency Medical Treatment and Labor Act, and disentangling the political rhetoric and narratives from the legal and medical facts about how it impacts obstetric care. I hope you enjoy, and I'll see you at the end of this episode.
Welcome to Caring for Both, a curbside consult series by the American Association of Pro-Life OBGYNs, or AAPLOG. On this podcast, we bring on experts to provide insights to support you as a medical professional in your life-affirming practice and career. I'm your host for today, Dr. Christina Francis. I'm a board-certified OBGYN and also CEO of AAPLOG. Today, we are going to be addressing the topic of EMTALA, which has been a hot topic in the news actually for the last few years, even though it's been around for a lot longer than that, with the Dobbs decision that changed the abortion legal landscape in the country. EMTALA really kind of came to the forefront in the discussion of what is an abortion, what is not an abortion, and in the context of providing emergency care to pregnant women who are facing medical emergencies. Most recently, the Trump administration reversed guidance on EMTALA actually back to what it was pre-Dobbs and back to what it was before the Biden administration. And out of that, there's been a lot of discussion that maybe the Trump administration changed it so that women can't receive emergency medical care. And so there's a lot of controversy out there about how this change, the previous change under the Biden administration and then the current change back under the Trump administration, might be impacting patient care. So this is a very important topic to talk about. And I think just for people, the general public, to understand what EMTALA is as well and what it was meant for. And so we have with us today to offer his thoughts on this, Dr. Sean Hutzler, who's a board-certified emergency medicine physician who practices in Corpus Christi, Texas. So he's practicing like me in a state that has strong pro-life protection. So he certainly has experience in this. He has experience in a wide variety of emergency medicine practice settings, including large academic and referral centers, rural emergency medicine, community emergency medicine, as well as freestanding ERs. And while he's primarily a clinician, he also teaches residents that are on shift with him and in a lecture-based curriculum through the local emergency medicine residency program. So certainly has a lot of expertise to offer us today. In addition to chairing the emergency medicine subsection of AAPLOG, he's also an active member of the Catholic Medical Association and writes blog posts for one of our favorite pro-life organizations, Secular Pro Life, regarding life and emergency medicine issues. So it's such an honor to have you with us, Dr. Hutzler. Thanks so much for joining us today. Absolutely. Well, let's just jump right into this topic. I think, a lot of our listeners are medical professionals, so they will likely know what EMTALA is, but we have a lot of non-medical people that listen and watch our podcast as well. So can you explain, particularly for them, what is EMTALA and how does it impact those of us who are seeing patients in an emergency room? How does it impact our practice on a daily basis?
This is a topic that honestly lots of doctors and hospital administrators don't understand super well, and so I'm happy to be able to talk about it. This is something that every emergency physician in the United States is thinking about constantly, whether they're actively thinking about it or it's just sitting in the back of their mind. And so it really affects every aspect of providing emergency care in the United States. Essentially, what EMTALA is, it stands for Emergency Medical Treatment and Labor Act. Okay, and that was passed in 1986 as part of a bigger, giant omnibus bill. And its intent was to prevent hospitals from dumping patients that were complex or were uninsured or underinsured on other hospitals, which is something that is maybe alluded to in popular media surrounding medicine these days, but really just doesn't happen a whole lot anymore because of this law. And it's a great law for that reason. And its stipulations are that whenever an individual comes to a hospital that participates in Medicare, okay, so that's the main thing, but that's 90% of United States hospitals or more. They have to receive a medical screening examination looking for a medical emergency. And that can look like a lot of different things. Okay. There's no stipulation on who has to provide that exam. In some hospitals, especially rural hospitals, for a long time, that individual could even be a nurse. Okay. It doesn't necessarily have to be a physician, but they have to have an adequate screening examination for emergency medical conditions. And they have to do that regardless of ability to pay. And with some amendments to the law over the years, it basically means that they cannot delay that for any reason, including, asking for identification information, insurance information. And that applies to everybody. It applies to U.S. citizens, to non-citizens, regardless of any defining characteristic of the patient. And that's really important. And that medical screening examination could include just an exam, just looking at somebody and examine vital signs and history. It could include CT scans, laboratory work. You have to do whatever you need to do, whatever is indicated clinically to rule out a medical emergency or to identify one if it's there. And then the second part of it is that the hospital and physicians that are in the emergency department or are listed as on call for the hospital have to provide, within their capabilities, stabilizing treatment for any medical emergency that's found. And if they don't have the capability to treat the condition, they have to arrange for a safe, appropriate transfer to a facility that will be able to provide that care. So, and then again, all of this regardless of ability to pay. Doesn't mean that they can't bill somebody afterwards, and that's codified in federal law, that you can ask for payment, and there's some stipulations about that. But essentially what this was meant to prevent was doctors that are listed as on call for a facility just being flippant about who they see, just picking and choosing which patients that they want to see. If a surgeon wanted to, not knock their complication rate or mortality rate, they could just say, I don't want to see this patient because they're too complex or they're not established with me in my practice. That did away with that. So if you're listed as on call for the hospital, you have this obligation to provide this stabilizing care. Yeah. And actually, one of the first cases that was prosecuted under EMTALA, this is in 1986, happened not too far from me in Victoria, Texas. And it was an OBGYN who was listed as on call for the hospital. And a woman in active labor came to the emergency department, and then he essentially refused to see her. And then eventually he did make some sort of contact with her, but she was in active labor, and it's unclear, I think, from the documentation whether he acknowledged that. But then he put her in an ambulance and shipped her to what he felt was the nearest appropriate facility, which was like 4 hours away. And she delivered en route, and she had some complications with the birth. And so, but that was one of the very first cases that this law was applied to, and with good reason. I mean, he was wrong to do that. Since I'm always there, I'm always in the ER, and I got to see whatever walks through the door. I do get a little frustrated sometimes when I have specialists that are, maybe not as willing to come and see somebody. But whenever I suspect that there's an emergency condition, that all I got to say is EMTALA, and
Yeah.
to it.
Yeah.
And the reason that is it used to be $50,000, but now it's $120,000 personal fine to a physician, up to, and the same thing for the hospital. Okay, that for each instance of a violation, they can be fined up to, I think, or $119,000.
Yeah. Yeah, absolutely. Well, that's such an important point to make, and an interesting and sad case that that first prosecuted case that you bring up. But it perfectly highlights, what EMTALA was put into place to prevent, which was, as you said, abandonment of patients, or even in a situation where I'm not sure what the situation is at your hospital, but where I work, we're a community hospital, but a large community hospital where we get referrals from smaller outlying community hospitals that don't have as many resources as we do at ours. And so we'll get those transports, when patients need to be transferred for a higher level of care, we're the ones receiving them. But even those smaller community hospitals, before they put that patient in the ambulance, they have to, as you said, ensure that they've done everything that they possibly can with the resources that they have to stabilize her prior to transport. So, giving her IV fluids or maybe blood, or ensuring that she's not getting ready to deliver if she's somebody who looks like she may be in preterm labor or an active term labor. Before putting her on that ambulance, they have to ensure. And interestingly, with EMTALA, there is actually a provision in it for women who are pregnant that acknowledges the unborn child as well, that says that hospitals have to stabilize the mom and her unborn child, again, as you said, to the best of their abilities with the resources that they have prior to transfer. So this is actually a very good statute that ensures that patients are receiving the best care possible before they're being, shipped off. Certainly something that I've seen over the course of my career is, like you said, a physician not wanting to come in at an outlying hospital and just telling them to transfer the patient without coming in and evaluating her themselves. And that can cause real problems for patients. And so that's what EMTALA is meant to prevent, is, as you said, ensuring that we are stabilizing people who are experiencing any kind of medical emergency, that medical emergency is being addressed immediately, and then them being transferred to a higher level of care if that's what's needed to appropriately treat them.
And the flip side of that, and this is actually where a lot of facilities have gotten pegged. And I was looking, so CMS publishes basically whenever they have a judgment against somebody under EMTALA, and there's only been one instance in the last 5 years, or at least 2 or 3 years, that I could find that was a judgment against an individual physician rather than a facility.
Okay.
And that was failure to accept a transfer. And so,
sure.
So from the the receiving standpoint, because I do a little bit of both, I do some sending and receiving. You're, as a receiving facility, it's not your job to determine whether or not the sending facility has capability. All you are supposed, and you can down the line say, well, they ought to have been able to handle this, and there's channels for that. But in the moment, if somebody's calling for help, if you have the capability at your facility, you have to say yes. And that's another kind of poorly understood aspect of the law. So if somebody has a general surgeon on call out in Podunk, Texas, and they want to send a surgery patient to your bigger city hospital, it's not a right now thing to decide whether or not the surgeon out there has the capability. If you have the capability, you should say yes. So
yeah, absolutely. Well, I think there's been, as I said in the beginning, since Dobbs, there's been some confusion, I think, some narratives that have been out there about EMTALA and about abortion. And that, I think, the confusion was certainly contributed to by some guidance that was issued under the Biden administration that was attempting to say that EMTALA would mean that abortions needed to be provided in an emergency context. Now, certainly you and I both know, both physicians that are seeing women come in with obstetrical emergencies in the ER, that there are times when a pregnancy needs to be emergently ended because of a life-threatening complication for a woman. And certainly that would fall under EMTALA. But there have been some other political narratives out there about that. Can you just give us some of your insight into what's happened maybe over the last few years that has caused some of this confusion? And maybe it's been on both sides of the issue, but how has this EMTALA regulation, which really is a good regulation to ensure that people get the care that they need, how has that maybe been twisted and pulled into this abortion narrative?
Sure. Well, I think the main thing here is that there's a narrative that is ongoing and that's pervasive in the whole life abortion debate, that abortion is healthcare. And so to deny abortion is to deny some essential aspect of healthcare, which is obviously something that AAPLOG disagrees with, that I disagree with. And there was this feeling, because there's this narrative that abortion is healthcare, any attempt to block that or block access to abortion is seen as putting women in danger. And it's important, I think, to talk about what is an abortion, what is popularly considered an abortion, what do people mean when they mean, access to elective abortion, and what is that? Secular Pro-Life, who you mentioned earlier, is actually, I'm not sure if she's published the poll yet, but she did do a poll basically with a number of different situations, and from a layperson perspective, what constitutes an abortion. So for medical professionals, something like ectopic pregnancy management is not an abortion, is not considered, certainly not considered an elective abortion. Complex miscarriage management, a woman with an open cervix, at 15, 16 weeks, that, addressing that situation, even if it means essentially augmenting a process that's already happening, with labor, is not an abortion. Okay. Abortion is the direct intentional killing of a viable unborn child, right? And that situation is not a medical emergency. And there are extremely few cases where you would even consider applying that terminology. And I think that has played out in the legal discourse and the back and forth. So actually, part of the reason why I was ever even brought to the attention of AAPLOG or got involved with y'all as an organization was because in July of 2022, right after Dobbs was handed down with the Supreme Court, the Biden administration and Secretary Becerra, under the Health and Human Services, issued this guidance that basically stated that in their capacity as CMMS, that's Center for Medicare and Medicaid Services, participating facilities, hospitals had to provide abortion care to the degree that it constituted stabilizing and treating medical emergencies. And when I read that, I was kind of furious because it didn't really make any sense, and it was clear, and I wrote about this for Secular Pro-Life. It was clear that to anybody who's in practice that this is just not, it's not reality that they're talking about. Elective abortion care is not something that people need access to as a way to combat true medical emergencies. And Texas, among other states, sued. They sued the Department of Health and Human Services to say, no, like this is ridiculous that you guys are using this federal department to bully states into allowing or providing abortions. And AAPLOG wrote an amicus brief on that. The CMDA did as well, and that worked. Okay, Texas won an injunction basically preventing HHS from issuing that guidance. There is the other sort of active case in that realm is Moyle versus United States versus Idaho. Idaho has an extremely stringent abortion law, and initially the Biden administration sued the state of Idaho regarding that, and they, through some technical legalese that I, to be perfectly honest, don't fully understand, the Supreme Court backed down to a lower court ruling, which essentially allowed Idaho to continue. the exact wording of it is not particularly clear, but the wording says that they allow Idaho hospitals to continue providing elective abortions insofar as it is covered under EMTALA. But as we just talked about, that is not something that really happens. And so the Supreme Court, the United States Supreme Court, didn't really address the merits of the case. It was about this whether or not this lower court had the ability to do something that they did. And then Trump gets elected in January of 2025, and the federal Justice Department stops pursuing that case in March. So there certainly has been some back and forth there. But then also, after the federal Justice Department stopped pursuing a case against the state of Idaho, there's a private hospital system, St. Luke's in Idaho, that is now in process to sue the state of Idaho, basically over their right to provide abortions on an emergency basis. And it's unclear how that's going to play out. There was another case that you guys may be aware of in Texas, where it's a class action lawsuit with several patients and two OBGYNs actually about basically not related to EMTALA, but sort of tangentially related, suing the state of Texas regarding our abortion laws. And essentially saying that, using these case studies of these women, that they had to travel or they had to incur on some undue burden in order to get an abortion that would not have been allowed by Texas law. But here's the thing, though. In those cases, nearly universally, these women were stable. Okay, so they're not having an immediate right now medical emergency. Do they have they had a problem? Sure, some of them had pregnancy complications and other things of that nature, but they were not dying. Okay, and not to necessarily be flippant about that, but I probably more than other physicians, other than maybe like critical care doctors, or I am actively dealing in whether or not somebody is actively dying. And so if you've got time to go and get something done or cross state lines to get something done as an outpatient on your own, then you're probably stable. All right. And you probably are not, your condition likely does not qualify under the definition of an emergency medical condition under EMTALA. Right. And so EMTALA is used in this sort of nebulous way to invoke healthcare in general, but it's very specific about the types of conditions that it covers, and that there was actually some contention in the Idaho Supreme Court case about that, and about trying to get people to pin down what exactly was and wasn't an emergency medical condition. And then we start talking about, well, what's an EMTALA violation versus what is just malpractice? What is just, the physician in front of the patient not addressing their most immediate medical concern. And that, and so that's the way that EMTALA, I think, from my perspective, has been used in that political narrative.
Yeah, absolutely.
Thank you so much for watching part 1 of this episode. I look forward to seeing you next week for part 2.